retina. Dr. Zai Kelkar, consultant eye surgeon, cataract and pediatric ophthalmology, and Dr. Pankaj Bendale, consultant eye center, cataract and glaucoma surgeon, again from NIO Pune. The cases which will be demonstrated are phacoemulsification with vitrectomy, flax with refractive cataract surgery, and phacoemulsification with glaucoma surgery. I have with me my co-moderator, Dr. Rajesh Sinha, who is also the treasurer of All India Ophthalmological Society and professor at All India Institute of Medical Sciences, RP Center, New Delhi. And he would be introducing the next guest.
Yeah, it's a great honor to introduce somebody like Dr. Jignesh Taswala, who is so close, very close to me. President of MOS. Can you just go back? Is the president of MOS. Yeah. Then Dr. Juta Machwe, who is the secretary of POS, Pune Ophthalmic Society. And Dr. Sanjay Tekawade, again a personal friend, is the president of Pune Ophthalmic Society. We also have with us Dr. Shrikant Kelkar, who is the, everybody has loads of respect for Sir, who is the founder of National Institute of Ophthalmology, a father figure, and a wonderful ophthalmologist and a great human being. So it's a great moment for all of us to be here in this Surginar that is being relayed from National Institute of Ophthalmology.
So we are going to go live from the National Institute of Ophthalmology, Pune, and we would like to thank them for letting us peep into their operation theaters today. And I believe we are going to be live from 2 different centers of NIO, which again is a unique feature which has never happened before at the AIOS Surginar. And we are very grateful to Dr. Aditya Kelkar, Dr. Zai Kelkar, and all the other supporting staff and supporting team from NIO for doing this Surginar today. Over to Dr. Aditya Kelkar for his comments. I think, Aditya, we can't hear you, but I think what I have been told is that there is going to be a inaugural ceremony for this.
Can't hear Dr. Sanjay speaking, but.
So Aditya, we can't hear Dr. Sanjay speaking. Maybe on the Zoom link we can have their address. So I think we can begin with the lamp lighting ceremony, Dr. Aditya. We would like to welcome Dr. Sanjay on behalf of Dr. Aditya Kelkar for gracing the occasion today. The President of now we can hear you, Aditya.
Yeah.
We can hear you
now we can hear.
We can hear you, Aditya.
Again gone.
So, Dr. Zai, are we starting the first case?
We are ready with our first case. So it's a grade 2-3 cataract, and we'll be doing the femtolaser cataract surgery for him. So the settings that we have done for the femtolaser are already displayed. So now we'll be docking the patient.
Okay. So
we'll start now.
Yes, we can see everything very clearly. Can we have the view from the NIO operation theater, please? Can we have the spotlight on the NIO operation theater, please? Yes.
Yeah.
Yes, Sai.
Yeah, so you can see me, so docking the patient ना थोडं खाली बघा, नजर जरा खाली करा, अजून जरा खाली बघा थोडं, ठेवा बोट दिसतंय, दोन्ही डोळे उघडा, मी दिसेल, थोडं खाली बघा, खाली घ्या, थोडीशी नजर खाली करा, बस. अजिबात हलवू नका.
So, Dr. Jay, this is the Catalyst platform that you're using?
This is the Catalyst platform that we are using. I've docked the patient now. I usually prefer a slightly bigger rexis, so the settings are 5.5 millimeters for the rexis.
So what grade of cataract is it?
It's a grade 2 plus type of a cataract.
Okay.
It's a well dilated pupil, and now the machine is doing the OCT, which will give us all the parameters as to the anterior chamber depth, the size of the pupil, the pupillary distance, the wide to wide dimensions. So once I click on approve, then it goes through the planning stage. Here it tells me how much my capsular rexis size is going to be.
So what is the size of the capsular
It's
rexis?
5.5. I prefer a slightly larger rexis, so it's 5.5.
Okay.
You have a choice from 4.5 onwards. And sometimes if the pupil is small, then the catalyst system will tell you that it's intersecting the iris, and then it will go to the next program, which is the pupil maximized, wherein the machine will choose what will be the ideal size for the rexis. So once I've approved, the capsular rexis takes about 1.6 seconds. And now it's proceeding with the fragmentation. The total time for it is 27 seconds.
So you have actually put a chop pattern there.
Yeah. So there are different kinds. You can do a lens softening. You can even choose not to do the lens softening, depending on the grade of the cataract. So now we are done with the femto. So we will be undocking the patient. डोळे मिटा. आता लेझरचं काम आपलं झालेलं आहे. We tell the patients that it's a two-step procedure. First, the laser will be done, and then they will be shifted inside the operation theater for phacoemulsification and putting the lens.
I guess the beauty of this system is that the capsular rexis takes very short time, and even in a wide cataract, you can complete your capsular rexis.
Yeah, the settings sometimes need to be modified if it's a wide cataract, but yes, capsular rexis in a mature cataract becomes much more easier and predictable using the catalyst.
Yeah.
What we are planning here is first there are 3 cases that we have selected for the femto cataract. So we are showing femto, first 3 femto procedures we will show, and then I will take the patient inside and then be putting the lens. So we'll finish our work here, then I will wash and I'll be going inside. So any questions so far while we get the next patient?
So what are your plans? Like, what are the lenses that have been planned in all these 3 cases?
Fortunately, for all 3 cases are very well dilated. Personally, I feel that if the pupil is very small, then the femto will make a very small rexis because it will always consider the pupillary diameter. So if it's a very, not so very diameter, then I do not prefer to take these patients up for femto. So for me, at least, a good dilatation is a must if you want to undergo femtocataract surgery. Because then only you are getting the advantage of getting a good size rexis, and then you will not be struggling so much with the hydro procedures. And even though the lens softening has already been done by the machine. There is a small amount of learning curve which you have to adapt to when you are doing patients with the under femto.
I think, Dr. Jai, you have to turn to the opposite side because.
Okay, you can see my back. That's what I'm saying.
Yeah.
Okay, I think this will be.
Yeah. So, what are the IOLs that you have planned in all these three cases?
There are a couple of toric patients, and one has a synergy.
Okay.
So we'll be putting the synergy lens in the. There's a young female, 49-year-old. She's a housewife and doesn't drive much. But synergy, I find that it's very good. It doesn't give that much of a glare as the trifocal lenses has a wider range of vision for near. You get an extended range of vision with that.
True.
And there are two torics also. So with the Callisto system, we can maybe display that as well. How the positioning of the lens is done in the eye.
Okay.
So now we have taken our next patient for femto laser.
Mm-hmm.
We're operating the right eye.
Is the nuclear grading in this?
Yes, we are ready with the second case for femto.
So what grade cataract is this one?
Sorry, sir, I didn't get you.
What grade cataract is this
It's
one?
also a grade 2-3 type of a cataract. And the pupil is not as large as the first patient, so maybe we can display the pupil maximized mode in this case.
Okay, wonderful.
I think pupil maximize mode is something, which is present here in this machine, and I'm not sure whether it is present in other machines. Rajesh, maybe you can, talk about it. Is it present in Venture?
No, this mode is present in this machine, and it is a wonderful way to have a nice sized cataractus with this mode. So
Yes, so here it tells me that the capsulotomy is going to intersect the iris. So you say OK and you choose pupil maximized.
yeah.
So now it has reduced the rexis diameter to 5 millimeters.
Okay.
To which I say approve. And now we start with the laser. So 1.6 seconds and the rexis is over. And about 18 to 20 seconds more, the fragmentation will be done.
Okay. And the ones that you have not included is the condensation, right?
Yes, sir. So here we are not doing the wobble or the softening because the lens is not that hard.
Mm-hmm. So what is your preferred mode? Like in soft cataracts, you prefer chops, you prefer fractals,
I don't. Earlier we tried softening, but then we found that there's a lot of gas bubble accumulation in the bag when we do the softening procedures. So of late we stopped doing the softening procedure. We just do the fragmentations.
Mm-hmm.
And that seems to work well in our hands.
Mm-hmm.
less energy for the phacoemulsification than you would normally. Say for a grade 3, 4, if you want to use about 40 or 50% power, you can easily get away with 25 or 30% power.
Very true. Very true.
But the trick is while doing the hydrodissection, you have to be very careful, release the bubbles very carefully, because otherwise the bag is already expanded and it can cause a lot of intra-bag pressure if you are more harsh with your hydro procedure. So be more gentle than you normally are, because it's already softened. You just have to release the air and the nucleus is going to be emulsified.
True. True. Some people, in order to release the gas, they hydrate through the incisions of the chops that have been made with the consultation. So the gas comes out a little bit, so it reduces some pressure.
थोडंसं वर यायला लागेल तुम्हाला. हो बस.
So here the exercise will again be 5.5, right?
Yeah, yes, planned is 5.5. She is a well dilated pupil. But that's my personal choice of 5.5. I feel comfortable with my phaco procedures if it's a nice bigger exercise.
Yeah. Okay.
आपण उजव्या डोळ्याचा करतो आणि वरती लाईट करतो. डोळे व्यवस्थित होतो, काही दुखणार नाही का बरोबर. फक्त डोळे व्यवस्थित, दोन्ही डोळे उघडतो नका, टाईट नका करू. फक्त रिंग लावते डोळ्यावरती. आरामात राहा, नका काही नाही दुखणार नाही. थोडं खाली बघा बरं. नाही, फक्त नजर खाली करा. नजर खाली नाही, पाय दोन्ही डोळे उघडा म्हणजे जमेल. खाली नाही बघा, हे उघडल्याशिवाय ना आपल्याला करता येणार नाही. खाली बघा पायाकडे.
I think this muscle maximizing mode is a great advantage with this.
Yeah.
Because otherwise, sometimes you will have to otherwise abort these procedures. It will really become very small. I think there's a question for synergy. Like, what is the diameter of capsular axis? So, Dr. Zaid,
yes.
The question is that for synergy lens.
I dock the patient, but I don't like the position of her eye, so I am releasing the vacuum and we will reapply the ring. The patient is little anxious and she has a tendency to uproll her eyeballs.
So the question is that for synergy intraocular lens, what is the size of your rectus? Is it 5.5 or is it 4.5?
काय म्हणतात ते कळत नाही. ओपन डोळे उघडा बरं. दोन्ही डोळे व्यवस्थित उघडा. त्याला 2 मिनिटं पण लागत नाही, ते काही दुखणार नाही. तुम्ही आरामात राहा, फक्त थोडं कॉपरेट करा.
I guess for
बघा खाली.
For any lens, the basic idea is that the edge of the IOL optic should just be covered, and that is the basic aim. So anything between 5 to 5.5 will do in this case. It should be very small, but anything between 5 to 5.5, in my opinion, should work with synergy lenses. And we could see that the first two cases went very smoothly. You need some patient cooperation, but it took hardly any time. So some patients can be anxious, but then once it's docked and docked properly, then the thing is done mostly. So that is the beauty of femtosecond laser.
Painful for the patient, but I can, as you can see here, since she squeezed, the vacuum is lost.
Yeah.
I think that way, especially in cases of complex cases like subluxation or cataract.
तुम्ही डोळा जर हलवलात ना तर हे नाही करता येणार. हे मशीन आहे ना, जर परफेक्ट असेल तरच घेतं, नाही तर घेत नाही.
Careful to do it because
घाबरू नका, काही होत नाहीये तुम्हाला.
steps are already done.
पल्स बीपी मॅडम
Prior to your
सगळे
beginning,
बघतायत, काही काळजी करू नका. फक्त डोळा व्यवस्थित
so,
Yeah, in complicated.
has a role to play.
नका असं, आरामात राहा, काहीच नाही.
Fight.
Yeah, definitely in complicated scenarios, femtosecond laser really is very useful, very helpful, because not only it reduces the ultrasound energy, it also facilitates easy manipulation, easy doing of the case, like in subluxated and in cases wherein you have some endothelial compromise. In all these cases, uh, assistance, I would say, of femtosecond laser is of immense value.
So when you Rajesh that you've done a thesis on flax.
After a little bit of verbal anesthesia, patient is doing fine. Now she is relaxed and cooperating very well.
Yeah,
There
sometimes
is
you
a
do
small
have to.
air bubble there, as you can see, but since it does not interfere with our maneuvers, that air bubble won't matter.
Mhm.
I think this is also a
Yes, now
an
here the
important thing.
machine has accepted the 5.5
Yeah.
Rexis.
So that's why I said the patient can be uncooperative, and before docking, one can have problem in telling the making the patient understand. But once the docking is done, then I mean your work is done, and you will go ahead and finish the work. So that's the beauty. You don't have to struggle
And
once
it's
the
a
docking
soft
is done.
docking, not as hard like the femto.
Absolutely, absolutely. It's a soft docking, and it doesn't damage the surrounding conjunctiva and.
डोळा बंद करा आता. So now we will be moving to the operation theater where we will be doing the phacoemulsification and put the lens.
Wonderful, wonderful. So what we could figure out is that the one thing was definitely striking, which I was really impressed, was the ease and the speed with which capsulorhexis was done. Because in a cataract which is white, which has liquefied cortex, therein if the capsulorhexis takes time, then fluid will seep in, fluid will leak out, and then it will prevent from a complete capsulorhexis. So that's the beauty of this platform. It does capsulorhexis very fast.
So I think it's a great platform from J&J, and they are coming out with newer modifications as the machine evolves. I know, Dr. Rajesh, that you've done a thesis with your candidate on flax,
Yes.
especially in cases where vitreoretinal surgery has been done. Can you just highlight what are the advantages, or how does it help in these cases as we move on to the
Yes, ma'am.
the next case?
Yes, ma'am. Sure. Actually, what we figured out was uh, first of all the second part of the procedure, which is the phacoemulsification. Actually, using the ultrasound energy, we could see that the duration of the second part of the procedure was much lesser. First of all, then second, the use of ultrasonic energy was much lesser, significantly lesser. Less endothelial cell loss, less cumulative energy, less damage to the endothelium. So this was one very striking feature. The second thing what I felt was that we compared it with the conventional procedure. And what we figured out was that in 40% of cases wherein there was no silicone oil in anterior chamber, while we were doing manual capsulorhexis, there was little droplet coming somewhere here or there. And that could come and touch the endothelium. So that is something which was not noticed at all in cases of flax when you're doing capsulorhexis. So there's no stress on the zonules at all when you are doing a femtosecond laser assisted capsulorhexis and nucleus chopping, etc. So that is the advantage. Further, I mean, whatever precaution we take while doing a tearing movement with the with the needle, with the cystitome, with the forceps, etc., you can still damage a little bit of extra zonules, which is already compromised in a case wherein you have done an extended vitreoretinal procedure. So that is also prevented. So that is something which we felt that in our study it was strikingly better when we're using femtosecond laser. And rest of the things were comparable, but these two things were, and these two are very significant because your zonules are important and your endothelium is important.
So I think, like we
Yeah.
were discussing earlier, in cases which have complex scenarios, flax or femto-assisted cataract surgery does have an important role to play. Maybe in the hands of a surgeon who's an expert, it doesn't matter whether you use flax or not. But like all the other technologies, I think this is going to be the technology of the future, or rather, it is here to stay and is going to keep evolving further. So,
Yes. Just wanted to add one thing. I guess in the hands of experts in routine cataract, there may not be any difference.
yes.
Complicated scenarios, it still helps in even the experts. There's a question, ma'am, that has come up. And Dr. Minakshi wants to know that, do you stain the capsule in white mature cataract for capsular excess?
So I think yes, you would like to react first, Rajesh, then I'll.
Okay. So if you are doing a femtosecond laser and doing capsulotomy with a femtosecond laser, and if you are absolutely sure that it's a free floating one, you can see that there's a retraction kind of a thing. There's a gap between the two margins cut at the, then you may not require staining. But if you have slightest of doubts that there may be some skip areas, it is always better to stain so that you know exactly that these are the skip areas wherein you just have to use a forceps to complete the capsular excess. Because in white cataract, there is some risk. If there's a milky fluid, there is some risk of occasional skip areas which can be there. So there's no harm in staining with the
It is always useful that once the Rexus has been done, just put in trypan blue dye to see, whether it is completely free floating or there are some tags there. So it is always useful to do it. Of course, you can get away without it also, but then I think to identify the bridges or the ridges that are there, which are still communicating and have not been cut or have not been incised, it is useful to stain it with a trypan blue, even though you are using flax. Of course, in all the other cases, it does have an important role to play. So I think, are they ready? I think Zai is ready. We can see her.
Yeah, we can see she's ready.
So are you ready on the... can we have the microscope view, please? Microscope view. Can we have the microscope view? No, the microscope view.
In a moment, they are doing it. आता हलू नका फक्त सरळ बघा. So I'm starting now.
Yeah.
2.2 millimeter incision. मावशी डोळा अजिबात हलवू नका. अगदी स्थिर राहा. I will be using intracameral oculan for her. Right now we have put parakin. She is anxious, so if she does feel that she is not comfortable with it, we can increase it with subtenance anesthesia.
Okay. Is this the last patient that you did?
Yes, the last one with the
Okay. That's a very good idea that if the patient is anxious, let's complete the procedure in that patient.
Yeah. But again, she'll sit outside and think and overthink.
Yeah. So do you make incision on the axis, on the steep axis, or this is your preferred axis?
Synergy, this is not a toric patient. So since I prefer the acid superiorly at the head end of the patient,
Okay.
and the axis,
Yeah.
it comes at 135, the incision side.
We can see a free floating capsulotomy capsule.
Yes.
Capsule.
So that's why I put visco first. Otherwise, sometimes it goes and sticks on the endothelium like a dissect flap.
Yeah.
थोड़ा मशीनचा आवाज आहे ना थोडा जड वाटत. Better to eat up the capsule first.
So our pieces are very much separate already, and what I can figure out is that Dr. Jai is separating a couple of ones while holding also very well. And the whole nucleus will get emulsified. In the same, I think, in few seconds only, Dr. Jai.
Yeah, exactly. So this is power of about 5.
The duration of femto laser was almost same as the duration of your emulsification.
That was quick work, absolutely, and the pupil is mid dilated.
Yeah.
So can we make it a little retro, because then we can possibly see the glow? Yeah. The microscope is fantastic, Zai. I believe this is a Bumera microscope.
No, this is the Zeiss. Other center.
Nice. Yeah.
You see Dr. Aditya and Dr. Pankaj.
And you like to do a bimanual? I think that is advocated, especially for flax cases. It always, is useful to do a bimanual rather than a coaxial.
If they ask me to use the coaxial, I'll have to learn it.
Okay. So we all began with coaxial and then shifted to bimanual. For you all, possibly, you begin with bimanual and you stick to it. So which intraocular lens are we planning to?
We are putting the Synergy.
Synergy, yeah.
I'll show you the lens parameters.
Yes.
In such a small pupil, it is particularly, bimanual is very useful.
Yes, and I think Zai is doing it absolutely effortlessly. You can't.
Yeah.
It's actually not so easy to do in a mid dilated pupil like this, but not mid dilated. This is a small pupil. I think it is hardly 3 or 3.5 millimeters.
The pupil does have a tendency to come down after.
Yeah.
Yeah.
So do you preoperatively also use ketorolac or NSAID in these cases of flax?
Earlier we started using, but didn't find much of a difference.
Okay.
Are you using that?
I think we are using
we do
non-steroidal anti-inflammatory drug, but I agree with you completely. Not that it makes too much of a difference, but the only thing is, suppose the pupil is small. Have you attempted a flax with a Malugan ring or with the? Okay.
Mostly, I find, would that be safe? Just take the patient inside, put the ring, again get him out of the OT again.
Yeah, that's very true. I think if the pupil is small, it is always better to go ahead without doing flax. But sometimes some people, they demand flax because they have gone through the internet information, and then in that case, on a couple of occasions, I have done it, but I don't advocate.
Yeah, I think that's an
We are putting plus 21 diopters Synergy.
Okay. So Synergy, as far as the material of the lens is concerned, it is the same as that of the Technis platform?
Yes, same.
And you are using the injector with a push injector or the one which has a screw in it?
One with the screw.
Okay.
The push one goes uncontrolled. This is a very controlled method. Screwing it in.
And what is the size of your incision, Dr. Jai?
It is 2.2 millimeters.
Okay.
Very nicely, effortlessly put actually. And
Yeah.
that is single-handedly with the screw kind of a thing. Sometimes difficult to do it, but very nicely.
Yes, thank you very much.
So, you actually demonstrated a small pupil phaco so elegantly and so nicely.
Yeah, the inadvertent risk. Yeah. दूसरा रेडी Here I make only 2 incisions. If the pupil is sometimes the iris is floppy, then sometimes I make 2 incisions for the irrigation aspiration. Otherwise, it's the main port and the side port always.
Okay.
It works well. No, but there's no heroics in that. If the safety is compromised, then I don't hesitate to make another incision with a side port. थोड़ा खाली बता.
I think Synergy is a great intraocular lens which gives a continuous range of vision.
Yeah, patients are very happy with it. Of course, a good case selection as with all the high-end IOLs is there, but once we have explained what to expect and what not to expect, 95% of patients will not complain. They will be very satisfied with the outcome.
That's very true.
Yeah, so though this lady was very anxious in the beginning, she allowed me to operate under topical anesthesia. And yes, so that finishes this.
Wonderful.
I see that you use a speculum which has a solid plate, and then is this the one which you use always?
Yeah, we use this speculum always. Yeah, it has the screw where you can adjust it, and if it's becoming too tight, the lids are too tight, then you can actually loosen the grip and reduce the pressure on the lids. सरा झालाय पट्टी लावते थोडा वेळ तुम्हाला सगळ्या बाकी सूचना सगळ्या बाहेर देऊ ड्रॉप्स वगैरे अगदी व्यवस्थित झालं काही काळजीचं नाही
Depends. Do you? What is your experience with the specimen? Have you? Do patients are satisfied, or do you think that they need some kind of a spectacle, or would you know, again, like you said, patient selection is very important in such cases. For which type of patients would you choose this lens?
Who have a lot of night driving, then there is some amount of glare till the neuroadaptation occurs. So we will not give them to people who are in a habit or are professionally drivers, or they have to drive, especially on the highways when the blast is full on the light, the people are driving on full beam, because unfortunately in our country nobody is going to drive on the low beam. But for housewives or patients who are retired who do not want to be dependent on glasses, people with say tremors, Parkinson's, all of them have a lot of, we can say, they are very happy if they don't have to depend on glasses for their reading. I operated my father last year, and earlier he used to be a voracious reader, but as presbyopia and later cataract set in, he just kept his books and reading material away. But with Synergy, he actually has a symphony which also works very well. He is back to reading. So always think of that. If you are a voracious reader, then yes, these lenses are definitely for you.
I can see that you have patched the eye, and many people, they say that we don't do that, we don't patch.
Yeah.
We also prefer patching the eye immediately after surgery for a couple of hours, and then only once the patient reaches home, then the patient pulls the patch. This is what I feel personally.
No, but there was a time when we had totally given up patching the eye. We used to put goggles directly on table. Then there is some amount of comfort in your mind if you patched it for at least till the anesthesia is off. It's better, I think.
Yeah, and the patient goes. These are all daycare procedures. The patient goes home, and in between, there can be some dust, etc., whatever. So, for a couple of hours, maybe.
And most patients prefer to put a patch. They feel better. Raghu, you put a patch, nice. Otherwise, they should put no patch, just goggles.
Yeah. They are also scared.
They are also scared. Yeah. So all said and done, we have to. We are after operating in India. There is a lot of dust and a lot of pollution and hygiene issues. The Western world is not putting glass patches. Doesn't mean we can follow. So the next case is a toric patient. But it is already about 5-10 minutes since we did the femto, so maybe the pupil, I am hoping the pupil has not come down.
What toric are you putting? Technic toric?
It's a technic toric, yes.
Toric they don't have yet in the market. They should come out with Synergy toric and intraocular lens also. Rajesh, you put lenses on the Torrec platform across all manufacturers.
Yeah.
Think, what do you think? How do they different? Do you think there's any difference, between the lenses as far as the rotation is concerned?
No, not much of a difference. If you do, 1,000 cases, then you will get some difference in rotation. And as such, rotation in hydrophobic lenses is negligible. So if you have placed the lens in its position and you have removed the viscoelastic from behind the lens, then the lens, the back surface of the lens is in a good apposition with the capsule, and hydrophobic surface has a good adherence with the capsule. So most of the lenses, they remain in position, and you do, 300, 400 cases, and then you will require to re-rotate only in maybe one or two. So mostly in most of the platforms, the lenses, they adhere well. They stick to its position well. What is most important is that the viscoelastic from behind the lens should be removed completely by going behind the lens and aspirating out completely. That is what I have felt.
We can see that they have at NIO Pune state-of-the-art operation theatre, and things are moving absolutely smoothly.
Yeah,
the way
very fast.
Yeah, wheeled in and wheeled out, and proper blood pressure, etc., being taken, and extremely efficient. And I think we really need to thank them for allowing us to peep into their operation theaters from the comfort level of our own houses without having to visit their operation theater and their city in this COVID era. And we are witness to excellent state-of-the-art surgeries that are being done from NIO Pune, and that too on a Sunday. When everybody must have come to actually do these procedures.
Everything is looking effortless, actually, and for a thing to look effortless, a lot of effort has been done earlier. That's why, that's the only way how things look effortless. So
no, but this is a great initiative by AIOS, and actually the pleasure is ours. But thank you very much for the kind words. काका डोळे उघडा बरं. उघडेच राहू द्या. आपण सुरू करू.
The whole team appears to be very efficient.
Yeah,
obviously, the credit should go to the team leaders.
Yeah.
One of the reasons being it's a Sunday, we don't have anything more lined up. So after this is done, we are planning on having a good, nice lunch. This is for him, I'll be putting a toric lens. So Chetan tells me the haptics for this particular lens are unpolished. There is something new which they have done so that the lens does not rotate.
Okay.
And he tells me they want to launch it very soon.
Okay.
Maybe it's available in Delhi. Things come slightly later in Pune. Light.
Can we have the microscope view, please? Can the audio visual? Yeah, perfect. Excellent. Wonderful view. We can see everything very clearly. Every single vessel of the eye is actually focused on our laptops. So that is the beauty of the whole thing. It is like peeping from the viewing side view of your microscope. Maybe better than that.
So these are the Callisto markings. Tells me where my incision will be. And this is the Z alignment, which will tell me how I am going to orient the lens.
I think they need to show you. They need to show us the monitor, please. Can we see the monitor?
Yeah.
So put the monitor in the main view, and you can put this in the inset. You can put the monitor in the main view. Yes, perfect.
Yes.
So we can see now that there is a line which is going absolutely in the center. What is the axis in which you are going to implant the lens?
0 degree. Yeah, 0 degree.
0 degree. So we can see also the side ports and the main wound which you are likely to make in this case.
थोड़ा खाली बघायचं. नजर जरा खाली करा. Hello.
Perfect. So what I saw was that Zai, you made the side port and the main wound together.
Yeah, I do that.
Okay, okay.
So I put viscoelastic so that the capsule won't be tempted to go and touch it and kiss the endothelium.
Now we can have the other view, please. The Callisto work is done. Maybe we can use it later when we put the lens. Perfect. Now, wonderful. Every single, every single thing is so well focused. So, do you do a very vigorous hydro procedure in these cases because
We're just releasing the bubbles when see a huge one down there.
okay.
But the lens is already floating. Just tilt it and it will come out.
Yeah. There's partial pneumodissection as well that is done. So I guess by removing the bubbles, gas bubbles, you can easily rotate the nucleus. Again, a wonderful free floating capsulotomy. And
Yeah.
Can we focus it a little bit? Can you take it a little bit towards you? I mean, we are seeing the speculum and we are seeing the eye. So we can just center it a little bit. Yeah, perfect.
आता हलू नका थोडा मशीनचा आवाज येईल आणि डोळा जरासा जोड वाटेल.
So the machine that you're using it is also White Star Signature Pro, which again is a great machine with excellent dynamics, especially the AC dynamics especially when you're doing phacoemulsification. The AC is really stable. And we can see that, the pre-chops which have already happened because of the femto-assisted laser.
very easily
Yeah.
separated, no?
Yeah.
Pies.
You just touch them and they separate.
So what are the parameters at this point in time that you're using?
And the phaco power is 10.
Okay.
The vacuum is 450.
Okay. So before we realize the phaco part is done only.
Yes.
So I think again a very wonderful demonstration of how the bimanual irrigation aspiration is done. So normally, Zai, you said you don't make the third port, but sometimes you may need to make. So
The temperature doesn't stabilize then.
okay. So then, what percentage of cases you would actually need to make it?
Very rarely actually. If you have not had a good valve incision at the main port, then sometimes it's needed.
Okay. Okay.
If it's a uniplanar incision, then the chamber won't stay.
So I think this is a great advantage of a bimanual that your 12 o'clock. In fact, everything is accessible. For
Exactly.
the furnaces, the pupil again is not very great here. It's not really too much enlarged. Maybe a shade better than our previous case. Just helps a little bit when you put the fluid, so it kind of gets dilated for you to see where the leaflets of the cortical matter are. But again, you did a great job, in that mid dilated pupil.
Bit of cortex.
This is a wonderful trick that you did, Dr. Jay. I really appreciate it. With the fluid that you dislodged, that some pieces that sometimes they get stuck behind the iris, some epinuclear material, sometimes they get stuck to particularly in hard cataracts, they get stuck somewhere. And with the help of a jet of fluid,
It helps.
it really helps and it dislodges.
See a very small tip which is coming out. Usually it's a huge piece which is.
Yeah.
This is the lens.
Okay, so this is a Technis toric lens, like you said, with unpolished haptics.
Unpolished haptics, yes.
So that it does not rotate.
Yeah.
In the bag post-operatively.
आता थोडासा pressure वाटेल.
And again, completely effortless. I think that was again a beautiful implantation of the intraocular lens. You like
the advantage of this? Yeah.
Yes, right.
The advantage of this unpolished haptic is also that they don't stick to the optic, and it's a little roughened in the stick to the optic and don't stick to each other. So that is the advantage. And also,
I think in the previous studies we used to have this problem that the haptics have got stuck to each other or got stuck to the optics, and then it's another task to actually detach them from there. So can we now have the Callisto view, because I'm sure Zai is going to be putting the lens in position, and I think it's a great challenge, Zai, to put a toric intraocular lens into correct position through the pupil, which is not that dilated, and you need to see the marks. Can we have the Callisto one? Yes.
Here are the marks and it's exactly overlapping.
Yeah, exactly overlapping.
Yeah, so the trick here for all torics is that the visco should come out of the bag, otherwise there have been rotations.
Yeah.
But maybe with the unpolished thing, that also must be obviated now that they've come up with it.
So I think that was excellent. And again, just for a split of a second, the pupil did dilate to make us aware of the fact that, those markings were seen bang on the 0-180. And again, wound hydration. Do you put moxifloxacin in your cases?
No, not putting. Initially, again, we did for a few cases and then stopped. We did that survey a few years back. Yeah.
So there was this AIOS survey which was done by Dr. Kelkar's group, Dr. Aditya Kelkar and Dr. Zai Kelkar, which looked at the people which asked whether intracameral moxifloxacin should be given or not, and in which conditions. And I think I think you are again going to do yet another one, because that was almost 5 years ago.
5 years back, yes.
So excellent, excellent case, right?
Thank you so much. Thank you very much.
Thank you. It was so effortless. I mean,
yeah, that is the word, effortless.
Effortless, absolutely. You finished it, like
part of the credit is to you both also. You've been very encouraging, because it didn't put on me, but it was flattering.
Actually, we can encourage, but the work has to be done by you only. Finally, it's the work that is showing.
Yeah, no, it was just like an absolute
just appreciate.
Cakewalk. Yeah, cakewalk kind of a thing.
Yeah, you can just appreciate and do nothing. The work has to be done by you only.
You're both excellent surgeons, so coming from you is a big thing for me.
So I know that, I don't know whether many people know, but I know that Zai is a great athlete also, and she really is into athletics and marathons. Am I right, Zai?
Yeah, yes. So today morning, Aditya and I, we both had our run, but only because of this program, we cut it short. Did about 10 kilometers only. Okay, so I think Aditya is ready. So we'll start with the relay at Shivaji Nagar. So thank you very much. It was a pleasure, and I'll join you at Surginar now.
Thank you so much. Thank you.
Thank
so
you.
much.
Thank you.
So again, this is a unique feature where from one institution is hosting the live surgery for Surginars at 2 centers, which has never happened before actually in our Surginars, Rajesh. I don't remember. Do you remember? We've not
No,
done it
no,
before.
no. It has never happened before.
Yeah, it's a great idea, and the surgeries are also really varied and different. So we saw phacoemulsification with toric lens, with synergy lens, and now we are going to also see the other kinds of surgeries other than phacoemulsification from the other center. So I think that was a
Dr. Aditya, can you hear us?
Yes. I don't know if
okay, we can also hear you. Yeah, great.
Right. So this is a 65-year-old lady. She's come with a history of decreased vision in her left eye, and she has got grade 2 nuclear sclerosis with macular hole. So we are going to do a combined phaco-vitrectomy for her.
Wonderful.
I've already done the capsular axis and eye2 dissection so as to save time.
Okay. So perfect. I think we've never had a demonstration of macular hole surgery on a Surginar again. And it's
that too combination of
it's going to be great to see both together. Something which people don't get to see, and that too unedited in its real life form, and that too from the comfort zone of our own laptops and our own homes. So thank you, Aditya, for doing this.
Thank you, madam, for this opportunity. So I'm halfway through with this nucleus removal.
So for retina surgeons like you, this cataract surgery must be hardly anything. It must be just one small thing in that big surgery that you're going to do.
Actually, both of them are athletes, no? So they run, they push the nucleus also to run away. So
as long as it runs away, outside is good. When it runs inside, it's always a difficult game. For a retina surgeon also to have that situation, I'm sure sometimes you miss your beats.
Yeah.
But great transmission. I mean, very nice microscope. You can see just about everything, every single vessel, every single, every single thing is very nicely focused. So, Aditya, you've not learned to do bimanual from the main wound and side wound from Zai. You made 2 side posts for yourself.
That is something that is unique to her, I think. So, I'll let her do that way.
So when you do a combined surgery, cataract surgery and macular hole surgery, do you like to combine it at the same sitting, or do you like to sequentially put it first?
No, I combine it. I usually combine the cataract with vitrectomies, especially if the age group is more than 50 years or 55 years. That makes it easy for us to even visualize the peripheral parts of the retina.
Okay, so you must be putting sutures, right?
Suture, it depends. I mean, now if you see my incision is 2.2 millimeters.
Yeah.
And it is almost 1.5 millimeters long. So usually I don't need sutures for this type of long incision.
Yeah, long tunnel you can manage without.
इसका थोड़ा लग रहा है इसको है ना
What is the preoperative vision of the patient? I mean, at what level do we normally go?
So she's 6/60 in her left eye, and she's 6/12 in her right eye.
Okay.
So I do expect some zonular dehiscence here. So I'm going to use a CTR before I remove this cortical matter.
Okay, perfect. I think inadvertently we've seen small pupil phacos and this CTR implantation, which is again going to be very useful for people who are, wanting to see how it is done.
What's the cause of macular hole in this case?
Age related. But I really don't know the cause of zonular dialysis in this case.
Yeah, that's why I was thinking that maybe it's a traumatic, then maybe that's the reason for zonular dehiscence.
Possible, I think, but there's no history of trauma. So I'm just inflating the bag, making sure that I visualize the anterior capsular excess margin here.
Yeah.
McPherson देना दूसरा.
So Rajesh, there are two. There's yet another model also which is there which can be injected. I haven't used it. You have the experience of using the one with
The preloaded ones.
yeah.
Yeah. It's very easy to insert. Obviously, the cost is more.
But this also looks very easy, and I think
It is also very easy. But in that, you just have to go till the bag and then you can easily inject. So I mean, both are doable and both are easily done, but that is easier, I would say. Definitely there's a cost for it. So
there are now companies, Indian companies also who are manufacturing the
yes.
From Adu, I think, with no financial interest in it, but
So I've stabilized the bag using the CTR. I'll take care of the cortex now. Hopefully the bag shouldn't trouble us now.
I think when you place the CTR, the cortical matter becomes a little tricky to aspirate, but because you're using a bimanual, I don't think that really should be a problem.
That too, if there's a tangential pull the way he's doing, he pulls tangentially, then it is pulled easy. In a radial pull, it can create problems, but in a tangential pull, it helps.
So first I'm removing the cortex which is in the area away from the dialysis.
Yeah.
And then I will put some viscoelastic underneath this area of concern.
Yes, that's
and then I will try to aspirate the lens matter. Sometimes even I use a intraocular lens inside so that this cortex becomes easier to remove without damaging the zonules further. So I will give an attempt of removal of the cortex now, and if it doesn't come out, I'll place the intraocular lens first and then take care of the cortex later. Take a visco. I will place the lens in first. So I will be placing the lens first and then removing the cortex later, because this lens haptic will also serve as an additional
counter support kind of.
Yeah, support to the back, and then the cortical matter should come off.
Yeah.
So this is which lens again? Is it Tecnis?
Yes, this is a Eyhance lens which I commonly use for combined surgeries, phaco-vitrectomies. And I'll make sure that this haptic goes inside under the cortex.
Yeah.
Let's go. All right, so now I have the lens inside. I will use this dry aspiration, sometimes also works well for removal of this cortex.
So Rajesh, you were talking about a suture to be placed, and I do remember remember that some of the retinal surgeons, even in our place, they like to put a suture there and then do a vitreoretina surgery or a macular hole surgery. So what are your thoughts on it?
Yeah, I mean that is something which is usually practiced. But what he has done is he has made a long tunnel.
Yeah, so probably we wouldn't.
It will have a better valve effect once he tightens the anterior chamber. So I mean, if one can do that, that is definitely very good.
Because I remember some of the sequentials that we do for our retina colleagues, they insist, that when we do cataract surgery,
that's why I asked this thing.
Yeah, you please put one suture, and sometimes they say you put two sutures, and they like to take the case maybe the next day or maybe in 2-3 days.
Yeah.
But I think this is also this is the advantage of, I think, being the retina and cataract surgeon both.
True.
So I've been able to remove most of the cortex. There is a small cortical matter left down at 6 o'clock.
Yeah.
I will not be very fussy about removing it. I will see if it comes off in one go. Otherwise, I would be happy to leave it there. Yeah. So looks good.
Yeah.
Yeah.
So now we'll go on to proceed to doing a vitrectomy. I will be doing a 25 gauge vitrectomy here. I'm not going to remove the viscoelastic from the anterior chamber right now, because as you know, there is a zonular dialysis. When I do a fluid air exchange, I may have a situation where the air keeps coming into the anterior chamber. So I will like to leave it there at the moment. And at the end of the surgery, if I can just tap a little bit onto the anterior chamber, make sure that there's no intraocular pressure rise. All right, so we are ready with the vitrectomy now. दुखता है? ठीक है, आता अपन थोड़ा सा इंजेक्शन देते हैं ना.
These sutureless vitrectomy is the 25 gauge, the 27 gauge, 23 gauge. These all have made life much
easy, absolutely
easier for retina surgeons.
Also, another care that I will be taking when I am doing the vitrectomy is not to do very close vitrectomy close to the posterior capsule now, because as you know, there is a zonular weakness there. So if I try to be too close to the posterior capsule, I might end up damaging the zonules more.
True. Now, a few years back, we could not have imagined that we can have a live surgical demonstration of retinal surgeries, but things have advanced so well that.
Indeed. Another precaution that I will be taking now is many a times the viscoelastic falls onto the posterior pole and it doesn't let the macula stain as good as it should.
Okay.
So right now I am doing a vitrectomy. Generally I would be little anterior first and then going back. But here I am slightly in the mid-vitreous to begin with. Just to make sure that I don't damage the zonules further. This is a stage 4 macular hole, so the PVD is already induced.
Yeah.
But I will obviously stain and check it once more.
So which stain will you use?
Brilliant blue.
So everything is very beautiful.
I'm just going close to the macular area, making sure all the viscoelastic is also aspirated.
We can see it very clearly.
Very clearly, yes.
This looks clean. So now we'll put in tricot and check if I have any posterior vitreous attached to the disc. थोड़ा इसको डालना हो कॉर्नर पे. Okay. Yeah, so there is a bit of posterior vitreous for us to induce PVD. Looks like.
Yeah.
That's the great advantage, I think. All retina surgeons are fond of using the various dyes, such as this tricot, brilliant blue. It definitely aids in visualization of the retina and the membranes. And in this case, the adherent, I mean, whether the posterior vitreous detachment is there or not, is easily visible now, thanks to the tricot. So what I do generally is create a small opening in the area near the equator, as you can see.
Yeah.
Anterior and the posterior vitreous is now separated. So this bowl of posterior vitreous attachments slowly and slowly, it's like a hydrodissection happens.
Yeah.
So similarly, a hydrodissection of this posterior vitreous will start happening, and that will allow us to do the PVD induction in an easier fashion. So once I have this opening made, slowly some amount of saline will keep flowing under the posterior vitreous, making PVD induction a bit easier.
Yeah, that will ease out. Beautiful. The view of posterior vitreous detachment is such a magnificent view, no?
Absolutely.
It gives so much of pleasure.
Absolutely. I would also consider this step as one of the rate limiting steps of a fellows in training. Once they achieve the step of inducing the PVD, I think the rest of the training starts going easier.
True, very true.
So we are doing a macular hole surgery here, so there is not much importance of vitreous base shaving in these cases. Of course, we must check the periphery in detail before we close the case. But here I am making sure that the posterior vitreous is detached and most of the cortex which is visible is removed before I stain the ILM with brilliant blue dye.
What's the setting of this of the vitrectomy cut rate?
Yeah, so I am using 7500 and cut rate, and the vacuum is 450. 7500 and 450.
Wonderful.
All right. Yeah. So I'll just show you, if possible, a view of intraoperative OCT. I
Okay.
don't know if you are able to see it on the screen.
I think they'll have to show on the monitor.
On the monitor, yeah.
Yeah.
वो monitor turn करके दिखाना.
External से monitor turn करके दिखाएंगे तो I think we will be able to see. Please focus on the monitor.
Yes, yes.
The view from the microscope is actually beautiful. We can see really very nicely. There, the microscope is really very good.
Clean करो ना lens.
Okay, we can see now the intrapository microscope also. I think we need to focus a little bit.
Yeah, correct. I'll do that.
So you've been using this intrapository microscope for how long now?
Yeah,
Let
I've been
me go
using this for
another.
now almost 2 years.
Yeah,
You can see the macular hole now.
yeah, we can
Yeah,
see.
we can see.
We can see very well.
Okay. So I've been using it for last 2 years. I find it quite useful, especially in cases of epiretinal membranes, and also in some cases where I've used it in patients where silicone oil was removed and the retina had a particular tinge of white due to long-standing detachment. So to confirm whether the retina is attached
Hmm.
or detached, I used this intraopacity. Apart from some submacular surgeries where submacular blood was
Okay.
taken care of using RTPA
Yeah.
injection. Hydrocannula. So as we keep injecting these external fluids inside the vitreous cavity, the intraocular pressure goes up, and I use this hydrocannula just to drain the excess fluid. गोळा नाही कमी आता मी इंजेक्शन सुद्धा दिलंय. So now you can see that the disc pulsations have stopped and the dye will take its own action. For about 1 minute we'll hold on. In the meantime, the patient has a little bit of pain, so I will top up the anesthesia and some more visco will be used in the anterior chamber. So the good thing is that the lens is quite stable now, and
The lens looks absolutely stable.
the caruncular block that I use for patients where if I have to
Okay.
top up any anesthesia near the medial canthus.
So earlier also in the, before you started the surgery, it was what kind of block was given?
What kind of?
Like, was it
Yeah,
regular only?
sorry. So Xylocaine and Sensorgain. So I use about 4 to 5 cc.
And the
of,
same way, curricular?
yeah, same.
Okay.
But the amount is much less when I give the caruncular block.
Yeah.
It's about 2 ml to 3 ml, as against what I gave initially was about 8.
Mhm.
I'm just waiting for the dye to work. Now it's already 1 minute over, so we'll go back and see.
So basically, you're waiting so that it should stain. That is
Stain.
why. Okay.
So now I'll just go back and see if the staining is adequate. Looks okay.
Yeah.
So what I'm aiming in this case, because the macular hole size is quite big, I'm aiming to do inverted flap here. So our usual trick is to put PFCL on the posterior pole
Mhm.
and then keep making a small circle of macular axis so as to fold these edges inside and then extend the axis later on in the second stage. So I will do 2 concentric macular axis. So the pressure goes up. I will use hydrocannula through the same incision and drain some fluid out and then reintroduce again PFCL. So it's like doing a paracentesis using
Okay.
26 gauge cannula. So now once the pulsations stop, I will reintroduce the PFCL. It is important that I have a uniform one single bubble. Otherwise, these small fish eggs are very difficult to remove later.
True. That's why you went at the edge of the previous bubble and then.
Yes, yes, sir. Just reducing the pressure again so that I can inject a little bit more of PFCL. We'll have to change the cutter. So it's just enough to cover the posterior pole. Once again, we have this IOP going up, obviously because of the PFCL bubble. I'm putting in 26 gauge cannula inside the vitreous cavity so as to allow some more fluid to escape. Now this happens usually because of the valved cannulas that you use, so there is no efflux of the fluid.
True.
And so this maneuver, although it takes a little while, it's still worth it because we don't want to compromise on the circulation of the optic nerve.
Yeah.
So as you can see, optic nerve has returned back to its normal color.
Yes.
And I will reintroduce a little bit of PFCL and then we will start the ILM peel. It should be good, right?
And with what instrument you would like to do the ILM peeling?
So I initiate my peel using the diamond dusted membrane scraper, and then I use the ILM peeling forceps.
Okay. Nice.
So this becomes traumatic.
Absolutely.
And I'm going to make these 3 or 4 small cuts on the ILM.
Okay.
So that these will become the inverted flaps under the PFCL. And because there is PFCL bubble and these small flaps, due to the capillary action, will get sucked into the macular hole. So there's no trauma involved in this.
Absolutely. It's looking absolutely atraumatic.
So I just leave it there and it automatically falls inside the macular hole.
Very nice.
So this is already covered. I don't have to do too much into it. And now I will make a second round. This will be for extending this macular peeling into a larger circle. So the inverted flap has happened without any trauma, and hopefully I'll do the same for the remaining ILM peel. So now I have to only enlarge this.
Yeah.
Mark it.
So once you have done this stopping into the macular hole, which gets closed, then what is the additional advantage of doing this removal
So
of?
it acts like a scaffold basically for the migration of the retinal tissue and aids in healing, aids in getting
No,
a
no, that is absolutely right. The removal from arcade to arcade.
Okay.
Yeah.
Yeah. As you said, yeah, what you say is right. I think maybe we need not do all this much. But as traditional teaching has been to go right up to the arcade, so.
The ones that have gone into the macular hole have been very nicely sucked into.
Yeah, the only thing is, maybe the point to consider is sometimes when we do the fluid air exchange, this flap which we have put in the macular hole comes off.
Yeah. So what precaution one can take or what steps one can take?
Yeah. So I will try to show you the way how we do it. First is I will make sure that the cannula is pointed in a nasal side.
Yeah.
And when I do the exchange, I'm very gentle about it. I'm not very aggressive in rapid removal of the PFCL. And also I will do a PFCL air exchange. So automatically it's more like a double sandwich of PFCL and air pressure that keeps this flap in place. I'm just completing the small residual fibers that I see. Just fashioning them out. That's all. So I believe we have a sufficient peeling here.
Absolutely. It's on up to one arcade. It's done. The second side are completing.
Yes. So I've just removed it. I think this should be more than sufficient.
Yeah.
So what I do now is, okay, I'll check if I can demonstrate one good quick OCT. I'll try to show if we can probably focus a good OCT here. So you can see probably the macular hole and the inverted flap inside.
Yes.
Okay.
I think. Yeah.
Yes. Now it's. Yes. Yeah.
So now I will switch to fluid air exchange. So I am on IOP 30.
Okay.
Because
the air PFCL exchange, right?
Yes. So now I'm doing air PFCL exchange. I'm making sure that I don't increase the IOP to 60 because I don't want air to come into the anterior chamber.
Okay.
Because of the zonular weakness that we have noted operatively. And how do I know whether the fluid has been removed completely? You can see this cutter is going down. It's in the fluid area. This is the air area. And so now there is a small transition zone. So I will go to the edge of this PFCL bubble and aspirate the remaining fluid.
Okay.
So that when I'm closer to the disc, I will not be in a situation where only fluid will keep coming out. So I will have removed most of the fluid. It's in the fluid area. This is the air area. So as you can see, the air has reached the border of the PFCL now. Okay.
Yeah,
and
we can see that.
My cutter will be facing superiorly, or I mean inferiorly or nasally. so that I don't have
Okay. Okay.
PFCL flap. Sorry, ILM
Yeah.
flap.
Dislodge the flaps.
And I'm very slow now. I'm not very fast in rapidly removing this PFCL. I'm taking time
Yeah.
purposely to make sure that the flap doesn't come out.
Yeah.
In spite of all these precautions, once in a while you will end up with a flap which comes out,
True.
but that's fine. Hello, Nakaji.
I think most of it is out now.
So as you can see, all the air is exchanged.
Yeah.
There is no fluid left, and the flaps are very much in position. All right then. So
Yes, the flaps are very much in position. We can see
yeah.
that.
So a quick scan of the peripheral retina to
Yeah.
make sure there are no inadvertent breaks. I am not going to indent now, obviously.
No. Yeah. But with the wide angle, most of the things are visible. So.
Yeah, correct. So with the wide angle, it's easy to see all the periphery. So I think it's all dried up. I don't have to be more invasive. And I'll be using SF6 gas, 20%.
Mm-hmm.
Thankfully, the zonules have behaved and they did not let the air slip into the anterior chamber.
Absolutely. Lens also very nicely inside the retinas, we can see clearly.
Yeah. So now this SF6 has been connected. I am putting one cannula through the superonasal port so as to allow the gas exchange happening. Keep injecting. So I use a 50 cc syringe.
Okay.
Resistance I have to bolna. And I do 20% SF6 gas injection.
Mm-hmm.
And I'm again very gentle because I don't want any pressure on the zonules here. So slowly exchanging the fluid, the air with gas. So now 30 cc is over. Now you can see it's 20, going to 10. And once I have a resistance, then we stop and pull off these no. So the check of the pressure looks good. And that's the end of the surgery.
Wonderful.
Thank you.
That was a wonderful demonstration of, macular hole surgery, as well as every step was very methodically and very properly demonstrated. I mean, a person who is, just learning retinal surgery will learn a lot from such a wonderful demonstration, because every step was very, very nicely shown, very nice.
Thank you. Oh. Thank you. Thank you.
Excellent demonstration, Aditya, and very nicely managed.
Thank you. Thank you.
For a person who's not into retina, I could also understand everything.
Thank you for your kind.
Yeah, Rajesh knows retina. I don't know too much, but then I think it was really perfect demonstration.
Yes.
Wonderful.
Thank you.
Yeah.
You do big things, and you're so
things went as per planned also.
Yeah.
As he had planned, the way he told, everything was behaving as if every structure is obeying his commands.
Yeah, I just wanted the zonules to behave a little bit better, but that's all right. In the end,
but that was also a good thing that it happened, so that you could demonstrate the other thing also.
Yeah.
Yeah.
So,
For us,
so
it was good. We have
Yeah.
yet another, demonstration of
yeah.
a thing. How do you manage it if it does happen? So I think
Yeah.
we had a very good presentation and very good live surgery.
Yeah. It was a treat to watch.
Yeah.
Thanks a lot.
Treat to watch.
Thanks a lot, sir and madam. So next we have a phaco with trabeculectomy, which is being done by Dr. Pankaj Bendale. He's a glaucoma consultant working with us for last 10 years. He heads the glaucoma department. He's been trained in Arvind Eye Hospital. He did his fellowship from there. And now he'll be demonstrating phaco and trabeculectomy in his patient.
Okay.
We had a complete package, Rajesh, with cataract and glaucoma and small
Cataract, glaucoma,
pupil and
and retina.
Actually, we wanted to
Yeah,
show one
retina
cornea case
and
too, but
retina.
unfortunately, the corneal transplant scenario is not very promising these days due to
Yeah.
COVID. So otherwise, we had planned another cornea surgery and oculoplasty surgery too, but unfortunately, due to shortage of time, we couldn't take it up.
Next time, Aditya, next time we'll
Yeah. Yeah.
Sure. So we are just getting ready with our patient who has been already given a block. Let me give you some details about this surgery which is going to happen next. Can I have the paper for the next case that we are operating? Pankaj sir's patient. Or we can pass it on to Dr. Pankaj. He's here now. I think maybe Dr. Pankaj, can you come here, please? So that he can give you all the details related to this surgery. Dr. Pankaj, please.
Yes.
Yeah. Hello, good afternoon, Dr. Pankaj.
Pankaj, or you have to be louder. We can't hear you. I think they've not put the mic.
Glomerular dialysis.
Yes, yeah. So am I audible?
Yeah, absolutely.
Yes. So this is the standard case, primary open angle glaucoma, and patient is on maximal medical therapy. Patient is on brimodine plus timolol combination. Patient is on dorzolamide. Patient is on latanoprost, and still the pressures are getting maintained around 24. CDR is a 0.9, and that's why we are planning phaco plus trabeculectomy with ologen implant.
Okay.
So I've already given the block now, and generally I just give only 3 to 4 ml blocks because I don't want too much of volume in the orbit. Because if we give too much of block now, it makes sometimes the eyeball tense, and which I don't like. So I like just enough akinesia. Even if there is some movements are there, that is okay. So analgesia is the most important. Some movements are okay. So and if required, then I give a below tenons, I give a preservative-free lignocaine. Oculan I give below the conjunctiva, which is the area of operation, and if required, intracameral also at the time of iridotomy. So I like to give only 4 ml or 5 ml of lignocaine. That's what is justly sufficient, and it is almost like patient is moving the. You can almost say like a topical one, but that gives me a lot of comfort because rather than having some any uneventful like this thing, peribulbar hemorrhage or any other thing that can really complicate the traps, and less hemorrhage is always good for the trabeculectomy, and I like as less bleeding at the site of trab also and in the orbit also, so that works best for me, and at least that works best in my hand. Yes.
And in what conditions you would like to do a combination, and where you don't prefer combination of,
combination, I always see. Once we do a perimetry, we know a lot of things about the staging of disease. So as mean deviation goes above 18, that is really a far advanced glaucomas where target pressure you would like to really keep it in the low teens, like 10 to 14.
Absolutely.
So these are the cases where I generally tilt more in favor of phacotrabeculectomy. But very mild glaucomas, OSTs, where pressures are very easily controlled on the one single medication, angle closure eyes, they do really well with the cataract surgery. So these are the early glaucomas where only phaco will do. But I think a lot depends on the stage of glaucoma and how the IOP is well controlled and whether patient is tolerating medication very well or not, compliance is good or not, comorbidities. So these were 4 or 5 factors that will decide whether we should go for phaco alone or phaco with the trabeculectomy combined decision. Yes.
And when you are combining it, you will do phaco from a temporal clear corneal incision and then superior.
No, that's what I learned at Arvind Coimbatore. I used to do a superior trab and then I used to do temporal phaco. But as I came to Pune, I slightly modified. So now this is the right eye. So supero-nasal, I will do the trab. And supero-temporal, I will do the phaco. So I will do the twin side phaco trab, but I will not change the position. Yeah, I will not change the position.
Okay. That's a modification.
But separate incision. But incisions are separate.
Yeah.
Separate. Yeah.
And the conjunctival flap that you will be making will be phonic.
Phonics based. That's what I standardly do now. Phonics based flap. So I will dissect the conjunctiva and tenons together. And with a slight nick, after once I reach the subtension space, I will put some oculant there so that anesthesia fluid dissects the plane there. Then I will just go there with the scissor and I will open the blade so that plane will get dissected. So I don't want too much of bleeding there. So I think this is a very important point for the beginners also, that while doing the trap, one of the most important delicate thing is subtension dissections. Don't do too much of oozing there, cutting tenons and all, because more you cut there, more oozing, bleeding, that will affect your trap chances. So subtension, subconjunctival dissection is a very important, simple initial first step of the surgery, but very crucial for a long-term bleb survival, because this is the one surgery where doing surgery just half job. How that follow over next 2 months, that is the most critical for maturing bleb and long-term success of trap. So you do it very delicately, you will require much less efforts in the post-op period. Otherwise, you have to then follow them very regularly, and a lot of other headaches comes, like regular massage, other things, 5FU or anything. But we should actively avoid that kind of scenarios by doing a very good meticulous dissection. That will give you the longest chance for the bleb to survive.
What about this Ologen? I mean, you must be importing Ologen.
Yes, I'm using for a long time now, yes.
For quite some time. So, how do you feel? How has it made a significant difference in the success of trabeculectomy?
See, one good thing now is a long-term bleb morphology. That is very fantastic with the Ologen. That can't be compared with MMC. MMT sometimes is not a very full titrated procedure. Some of the conjunctiva which are thin friable may overreact to mitomycin. Some which are a very like vascular conjunctiva and tenons, they may respond very well to it. So I think MMC sometimes has hit and miss. Sometimes it gives a very thin cystic blebs after 3-4 years, and they are not very really comfortable. Dysaesthetic blebs they become. Ologen, one very good thing, they have a very good bleb morphology throughout. So that's one very good advantage, and that makes one of the things more standardized also. Even if you are titrating the MMC concentration, amount of time exposure, thorough washing as per the friable conjunctiva or thick conjunctiva, other things and all, still there are variables in the mitomycins. So I think more than mitomycins, for the first case, like first surgeries and all, Ologen, that works really well. But I think Ologen alone won't make a big difference to the trap outcome. Ultimately, you are how to have a very good surgical technique, very smooth meticulous dissection, very good smooth post-op follow-up. Ologen is one add-on factor, but I don't think it standalone, it one will totally change the results of overall surgery from MMC to Ologen very favorable. Ultimately, how your baseline trap is, how your baseline trap technique is, how many sutures you are taking, whether one apical single only or 3 sutures, whether releasable or without that, all that are the factors that will determine the trap success. But in favor of both MMC and Ologen really, in my hand, it works very well with very good bleb morphology for a very long time and very comfortable blebs in long run. Yes. Yes. So I'll start. Case is ready now. Yes.
Please. Yeah.
Yes. Sorry, chair right, please. Yes. खाली बघा मावशी, अजून खाली बघा पायाकडे. सीझर प्लीज. येस मावशी डोळे बघा, खाली बघा पायाकडे, खाली बघा पायाकडे. येस हनवटी वर घ्या, हनवटी वर घ्या. येस अशी हनवटी वर घ्या. खाली बघा, खाली बघा पायाकडे, दोन्ही डोळ्यांनी खाली बघा.
So is it being done under topical anesthesia?
No, sir. I have given a 4 ml blocks. Yes.
Okay.
Yes. Yeah. Khali bagal.
But the patient is having some mobility. So basically, you don't want any pain. That's what.
Yes.
The patient should not have pain.
Khali bagal. Okay. I'll take a rectus. Yes. Please. Yes. खाली बघा मावशी. हो थोडं वाटेल मावशी. खाली बघा. खाली बघा. Yes, I think I will supplement. I think I will supplement, sir, 2 ml block, please. So intraoperative also peribulbar can be supplemented as needed. So even some of the topical phacos also, when they are not
Yeah.
comfortable, no, I think this was technique I use in my thing, where I give a supplementary peribulbar.
Okay. Okay. So what kind of a block you give? You give caruncular. Just now, Dr. Aditya showed a very nice supplementation by caruncular block.
Yes. No, this is not lignocancer, yes. And I give superiorly, yes.
Okay.
Only थोड़ा injection. So this.
So in lignocaine, you do include the hyaluronidase as well, right?
Yes. Yes, so this much is sufficient, I guess.
I think, yeah, we
Yes.
could.
Yeah. खाली बघा जरा मावशी. Yes. दूसरा speculum आहे का प्रशांत? I'll change the speculum slightly. Yes.
Yes.
नाही असं हे केलं दुसरं केलं वायरच केलं.
I think with the wire one, the furnaces would be exposed better.
Yeah, and plus bridle suture also, putting a bridle suture may be easier if there is no plate there.
खाली बघा मावशी. Okay. थोडं खाली बघा मावशी. हो थोडंसं टोचेल मावशी. दोनच मिनिटं. खाली बघा. So I tend to rectus.
Yes.
Yes, I tend to rectus. Yeah, झाले मावशी झाले. Scissor, please. So I have taken a rectus suture. Otherwise, no, I could have avoided this step. But I think no, there is some amount of less exposure also was there, and with the speculum alone, superior limbus was not getting exposed. But here also again, I will supplement slight oculan. That will give me a good subtenous dissection, and that will save my efforts of subtenous dissection. So I will just slightly lift conjunctiva tenons together. Will give a nick so that I enter into the subtenous space. Oh, oculan, please. Oculan. So this is oculan. That again will give me a good anesthesia at the site of surgery, which I prefer.
What is oculan? I mean,
preservative-free lignocaine.
Okay. So at the local site, it will give anesthesia.
At the local site always. Yes. Now, so see, this has already dissected the subtenous area and without much of oozing or anything. So now I'm just opening at the limbus, and see, subtenous space is already dissected by the fluid. I don't have to dissect anything there.
Yes.
Yes, so it's a bloodless dissection, and bloodless dissection is always favorable for the trap.
True.
Because then you need a less amount of and steroids and other things post-op. Yes. Yes, cautery, please. Okay, cautery, here. Just enough sufficient cautery is needed to avoid any oozing at the site of flap. But आता थोडंसं जाणवेल मावशी फारसं नाही काही डोंट वरी.
मागच्या बारीला नाही अजिबात काय जाणवलं.
Caliper, please. Caliper. So I generally take 4x4 flap. That's always a standard flap I take. Excellent. Rather than asking assistant, no, I always like some cotton there so myself can mop.
Okay.
So this 4 and 4x4 height flap, these are sufficient, yes. One good thing is not to have too much of oozing or too much of bleeding in the conjunctiva. That's a very good dissection. Go in the sufficient depth of half sclera. I take triangular flap. Many others are used to otherwise rectangular flap, other thing as per their comfort and as they routinely do it. But I think nothing much advantage or great difference between the results if your suturing technique is good.
Yeah. So how many sutures you put? You put one at the apex?
Yeah, I take only one at the apex. I don't take more than that suture. So I just close the trap with only one single apical. That's it. Because trap you have to do with reasonable aggressiveness. Too much of conservative trap will not give a sufficient good result. So,
True.
yeah, otherwise bleb works for first 7 to 10 days and you start finding the IOP again building up. And then you have to have a lot of post-op measures and all. So I think not taking too many sutures now is a good thing for the trap. Otherwise, then traps, then you are very on conservative side and then it gives a very moderate return. You might have to again supplement with the anti-glaucoma medication. Yes.
So actually, you don't need an assistant to mop it.
Yeah, no, I like myself because then I have a control on that. So, so always keep mopping up so that you will have the part which you want to dissect is always tense and it's a very easy and smooth dissection. Yes. Yeah. And as you reach to the limbus, surgical limbus, then for negotiating limbus, always good to have the crescent. So this much of intracorneal dissection is sufficient. At this stage, we leave this trap here and we'll move to the phaco part. Because flap we have to dissect before we enter into the eye. Otherwise, dissecting a trap flap in a soft eye or post phaco emulsification, we cannot do these steps. So always whenever we are doing a combined case, it has to be a flap dissected, then only enter the globe. So now here superinasally, I have done the trap dissection. Now here, at least I will leave 1 millimeter, 2 millimeter because one suture will come here. So I want to move little to the temporal side and from here I will do the phaco incision now. Yes, I'll put some oculan also because at the time of iridectomy, I don't want any discomfort to the patients. Yes. वरती बघा मावशी सरळ. And don't hold conjunctiva anywhere except where you are ultimately suturing. So you don't want any conjunctival buttonholing or anything. So always respect conjunctiva whenever you are doing phaco traps. That saves you a lot of headache. Yes.
Now, most of the people have shifted to the phonics-based conjunctival flap only.
Yes.
Is it because of the ease of?
Yeah, because that is easy technique for all kinds of your surgery techniques. So even if you want to do plain trap, you want to do any other things, still this phonics-based flap no is one technique that works for all kinds of glaucoma surgeries. Yes, as per the AC depth, you can always have your cystitome, how much needle you want to bend. So if for deep ACs is okay, otherwise for a very shallow AC, sometimes we encounter in glaucoma cases where you can't have that much of a long bend of the needle then, yes. So I always make it myself.
Yeah, in glaucoma cases, mainly sometimes the AC must be very shallow also. Then I think.
Yes. Sometimes PXFIs and all where there is zonal dialysis, sometimes you might encounter very deep AC also. So all scenarios you encounter into the glaucoma OT.
And doing cataract surgery in glaucoma cases is always tricky.
Yes.
Post trab or before trab.
Yes.
Any condition, it is tricky.
So do a very liberal good hydro because that saves you a lot of eye headache. So each surgical step has to be such that your next step should be made easy by the previous steps. Even unnecessarily like adequate rexis also is important because too small rexis also will give a lot of headache. And important thing is again having a very good comfort with your phaco machine, whatever you are using.
So which phaco machine you are using?
Now I'm using Stellaris. Okay. So I'm using 40 phaco power and vacuum. So for NS2 cataract, always direct chop works better. So I think as soon as you see the case through the microscope, you should decide with what kind of a technique of phaco you want to handle it. For a very soft cataract, don't make a mistake of small rexis, make it adequate size rexis because that soft cataract you can't handle with a very small rexis. NS2 to 3 stop and chop or direct chop is ideal. As little hardness goes, then stop and chop, and very hard, then 4 quadrant or maybe some debulking first. So for the most of the cataract, direct chop, that works very well.
Before we realize the phaco is already over in one sentence. Pankaj.
Yes, because that's what I will tell the youngster. As soon as you see the case through the microscope, decide what kind of technique you want to employ for this case. From soft to hard, I feel key. For a very soft, where there is just a PSC cataract, you can have even phaco aspiration only. But as it becomes the NS1 to 2 direct chop, NS3 maybe stop and chop, NS4 maybe debulking and maybe 4 quadrant. So that's how you should decide the plan rexis accordingly, and then phaco will go smooth. Yes.
I can see that you are really very, very well planned. I mean, each step is, well thought of, well planned from before only.
Yeah, because then next step becomes smooth and easy.
Yeah.
So you also prefer bimanual irrigation?
Yes, bimanual I prefer because I think the same technique for all the surgeon makes staff more comfortable in the OT. Even epinuclear sheet, I feel sometimes even if it is giving a headache, sometimes I don't mind using a phaco probe and using only IA setting. So technically, no phaco works there, but as the needle bore is more, then you can aspirate even the epinuclear sheet also very easily. So I think now the epinuclear sheet is loose from all the side. Sometimes this is the most common step where a rent happens. So youngsters should be careful at this step. Looks like the case is having some amount of primary PCO also, which I generally do hydration and I try to remove it. Polishing also is possible. But now this, as it was a dense PSC cataract, see, we can see a lot of primary PCO.
Yeah.
Primary PCO always better to handle by the fluid. Even if you clear the central area very nicely, that's sufficient rather than trying so much of heroic. So now see, I'm just hydrating I'm just trying to wash clearing the central PCs. That works well rather than going with the phaco probe, going with the IA probe and trying to handle it. So now see, yeah, so all that primary PCO now is well hydrated and clear. So that's a smooth, easy technique rather than trying polishing or any other technique which carries some due risk always. Experts find everything look easy, but I think beginners should go with the safest bet techniques. That works well. As you become master, then you can try anything as per your expertise. But initially, beginners should go very well smooth with the standard and safety first technique. Yes.
Which lens is this?
This is eye-enhanced lens, sir. Yes. I always prefer advanced glaucomas. I always prefer eye-enhanced lens, which gives good contrast. So my first choice is eye-enhanced for many of my advanced glaucoma patients. Yes. Yes. Now we'll come to again the trap part.
So when you come to the trap part, your viscoelastic still remains inside.
No, viscoelastic I will wash once I form the afterwards, because anyway I have to titrate the trap opening. Because once I do trap opening, I give a suture. I need to see whether it's nicely working or not. So at that time, so I will leave the visco at this stage into the antechamber. I'll finish the trap part suturing. Then I'll do the IA. I will titrate the trap opening, and then I will go for the conjunctival closures.
Okay.
So now this is where now I have entered for the punch here. Punch, please. So now Kelly's punch, that makes things very easy. 0.75 mm or even 1 mm punch are available. 0.75 is a good. Cotton, please. Cotton then. Wait karon then. So now go on making the punch till you come to the blue and white junction. So now 3, 4. See, I have made a 4 punch. Now I am at the sclera. Don't punch too much of sclera, because if you punch sclera, there might be too much of oozing. So this is a 0.75 mm punch, which is adequate. Now I'll do the PI. Wait, So this I always like, rather than having an assistant there, and bending their back. So it is better to have one wet, and this should always be wet, so that there are no any loose cottons there. So I always like that wet. So see, this is the trap opening that we have done. It is adequate in my opinion. So I will pull the iris from there, and this is one broad base PI I will make. So this is a sufficient peripheral iridectomy. And see, this. And now I'll take only one apical sutures that will close the trap. So I don't want too many sutures. Here we can have releasable also. Here, in this case, I will just take one single apical.
In which condition you would like to put a releasable?
Releasable whenever new vascular cases or any other tricky cases like uveitic eyes, any repeat surgeries. Yeah, these are the cases. Ideally, then the releasables are the best when you feel that these cases may heal.
Very well.
Yeah, these are challenging cases.
In future.
Yes. So, and here the tightness of this suture is important. See, I am now just tightening. I am not giving too tight suture, because giving too tight will cause a very rapid healing in that area. Again, lock the needle, lock the knot, because bring the both arms to one side and lock the knot. So then it doesn't become further loose by the time you take a second throw. The second throw and third throw. And that's what is the sufficiently needed. Yes. Yes. So just one apical suture, and that's it. I feel now I will go to the IS and I will do the visco wash. Because now see, we have done a punch, we have again covered that with the sutures. Now we'll wash the visco, and now we want to see whether the fluid alone is holding the AC or not. Because now this is called titration of trap. Now before proceeding for the conjunctival closure, I need to see whether that trap is under functioning, over functioning. Yes, so here I do the IA. Not only while doing IA, I always go to the PI area and try to see whether it's nicely patterned. Sometimes if it is lamellar, then you can pull that some of the remaining iris layer there with the IA probe, and that works better. So you will never have a issue of lamellar PI there. one important thing for the planning of rexis is always have adequate size rexis that will cover the optic from all the side, because you are going to give some post of cycloplastics like homide and atropine, so you don't want any optic capture. So while doing the phacotrap, one always should be thinking on mind how much rexis I want to do, and I don't want optic propping out from there. Yeah, so we have now done the IA, and now I will hydrate all the phacoports, and I want to see whether AC is nicely holding or not. So see, now all the phacoports which we have taken, we have nicely hydrated. So even that time also, fluid is not overly leaking from this area. AC is nicely holding also. So this one suture is also sufficient. I don't have to go to any extra sutures. So that's the titration of trap, and it's adequate. So at this stage, then I will proceed for the closure then. So I'll remove the rectus. This rectus also nowadays I don't take, but for this case I had to take it because exposure was less. Otherwise, the rectus step is also not a must step nowadays if you are feeling the superior limbus is very well exposed. Now here I'll put some visco. I always put some viscose here because then it forms some space there. Two raw surfaces of tenons and sclera remains away from each other. So I put some visco there, and then I put the ologen. Ologen, we have to just put it on the flap. You can make the ologen reach its place by the dialer or any hook. And then now we'll go with the vicryl sutures now to give rise to any watertight conjunctival closures. AC is all the time holding, there are no DM folds. All these are good indicators. Whatever one suture we have taken, that is adequately holding, and it is not over filtering, or you won't have surprises tomorrow of very shallow ACs or other things. That's why I said here I have kept some gap between phaco incision and trap, because one suture which I take, I don't want this incision to get distorted. Otherwise, if the incision of main phaco incision get distorted, it can cause leak and there will be issues. So always we should leave some gap between the traps and the main phaco incision. Yes. Now this is 80 vicryl that I am taking. It's a shot. So here again we have to take some amount of limbal bite because we don't want knot to migrate. So here I have taken some limbal. If I am lifting the needle, whole eyeball is moving. That means I have taken a nice bite of a limbus. We don't want to have only one superficial bite, otherwise the knot will migrate and it will not give very comfortable smooth healing to the bleb. So very small but important step where we have to take some limbal bite in this first suture. Next you can have only conjunctiva, but for the first you definitely have to have some limbal bite so that knot doesn't migrate.
Are there any times when you would have to remove this ologen implant? What happens to it eventually?
No, only in the case of infection remotely, I feel. Yeah, if there is, it gives the infection in first 3 to 4 weeks post-surgery, maybe. But otherwise, generally, we don't have to remove ologen. Means we have never removed in our so much of time. Yes. And always make sure that when you are tightening this knot, you are not distorting the main phaco incision, because if you distort, then sometime you might have to take one 10-0 nylon suture there. But generally it is not required. It doesn't distort that much. If you are left that much of gap between these two incisions, they are well separated and one doesn't distort the other. Yes, please. If the ologen is popping out before doing the next sutures, you can just reposit it with the repositor or dialer, any other instrument which you have. And now the second suture, I will have it on this side, which will then cause a nice watertight conjunctival closure. So now for watertight conjunctival closure, now this part should be very well stretched and nicely indenting the limbus so that no leak will be there. Yes. Again, for passing the second knot also, I will tell the same thing. See, this much of conjunctiva were dissected, so I will go here in the limbus and slight limbal bite. So see, a whole eyeball is moving when I'm moving the needle. When I'm coming out from the conjunctiva, I'm coming out slightly from the inner side, because then I know once I tie the knot, this area will get stretched and it will nicely indent the limbus and will give rise to watertight closure. Because unless there is a watertight closure, no, next day you can't massage the eye or you can't have any post-op manipulation unless conjunctiva is watertight closure. Because moment you will massage, whole fluid will leak like a waterfall on the cornea. So conjunctival closure is a very important step. Without that, you can't have any post-op bleb manipulation. You will have to wait till conjunctiva nicely get healed and then you can massage. But by the time then that flap bleb starts getting healed and then it's a very flat bleb that gets healed quickly by 2 to 3 weeks. And then pressures might again start rising. So conjunctival closure is again a very important step of whole trabeculectomy procedure. Without that, you have limitations in the post-op management. Now see, I'm tightening the knot. When you see this part is getting stretched and nicely indenting the limbus. So that's a very comfort for me. Ki even if tomorrow patient comes with a 40 pressure on post-op visit, I can massage and make it 10 immediately without any wound leak. So these are just the 2 sutures needed. I have not handled too much of conjunctiva also and without too much of bleeding also. So with the 8 times steroids, that's what I start. Generally just 2 to 3 days and eyes are absolutely quiet. So again, I'm just cross-checking all the parameters. Yes, conjunctiva is okay.
And in the area of Ologen, do you do anything to the tenons?
Yes, sir. Yes, so all okay, nice watertight closure here also. Yeah. AC at the same time nicely holding, no DM folds. These are good, all good endpoints. Maybe I would give 180, please. Maybe I'll give one more so that then it's more comfortable. Yes. Yes, but no sutures apart from this limbal area. No other sutures are required. Here it is slightly raised, so I will give one more here. Just that, then it's a very nicely watertight. Yes, because nice watertight suture. No, they give you a lot of luxury in the post-op period. Conjunctival sutures can be 2 or 3 depending on how much you are comfortable with that watertight closure. And 80, generally these get absorbed by 3 weeks. So by that 1 or 2 days, patient might feel some amount of pricking, but generally by 3rd week to 4th week, they dissolve and they are no longer required also at that place. Yes.
And I just had one question that what do you do to the tenons in the area where there is Ologen?
No, I don't touch tenons. I don't do any tenonectomy or anything because then I don't touch tenons. In fact, I just go directly into the subtenon space. I don't dissect even space between tenons and conjunctiva. I directly go below tenons and scleral area. I go there and tenons is not touch only. Yes. And I will pad the eye now with the atropine ointment. Yes, that's it.
Very nice.
Very nice.
Very
thank you, sir.
nicely demonstrated.
Yeah. And very nicely explained also, every step.
So if I have to refer a patient in Pune, I know where to refer the patient to, Dr. Pankaj.
Because this is just the hub job done now, and we have to follow this very nicely over next 2 weeks. In fact, 2 months actually.
Yeah. Follow-up is very essential in.
Yeah, follow-up is very crucial because without that we can't make this bleb very nicely work. How the healing take place, all that things, and now following this maybe twice weekly, that's what is really important. Each time I give the slight digital massage, I slightly raise the bleb, and I want it too much of aggressive healing should not take place. Now we have a lot of options available in our hands, like with digital massage, maybe some of the injections, needlings, and all these are the last options which comes in picture after maybe 4 or 5 weeks if there is a very aggressive healing in few of the cases. But this kind of option should not be required in first place. So now I start them with 8 times per day steroids, prednisolone, tapered slowly over next 2 months, one atropine, one antibiotic, and one NSAID. So this is what is the post-op regime that continues for next 2 months. Yes.
Excellent. I think we've had excellent demonstration of surgeries of all kinds. So
Yes.
this is one for the archives, today's Surginar.
Yes.
And thank you so much. I mean, it was really a great, Dr. Somewhere, there is a comment.
Dr. Seema has written that Dr. Pankaj is glaucoma guru in Pune. I mean, we can.
His
It
advisors.
was a demonstration of a guru only. The way you did it and the way you explained every point, it was like guru only. So he taught all of us very well.
Yeah.
I think all credit to you and Satyan sir also, from whom we learnt in Arvind Coimbatore, because I will tell you, your trap technique goes on maturing as you do more and more trap. You try to do then more steps innovatively and to your comfort with less dissection. So I think more you do will trap, more you will have your own refined techniques to give more better results, and almost with 90-95% success rate, because more and more challenging cases you do, some of the cases can be unpredictably, but I think 80-85% cases you should have a very nice bleb with controlled IOPs, and that gives a very good comfort to the patients, because quality of life of surgical patients is much better than those on regular medication. Yes.
So we had a great surgery. I can see Dr. Aditya there, and if we can have the whole team here in front of us. Thank you so much, Dr. Aditya. We missed sir. We thought we would see him. We missed sir today, but thank you so much, and thank you, Dr. Zai.
The Jai is not here, no? He's
in the other center. So
He's on the other center, yeah. So it was a very nice thing to do it from 2 different centers, and we also now know that there's a feasibility of doing this, and it was a very good idea to do it.
yes, ma'am.
And thank you so much, Dr. Aditya, for letting us look into your operation theaters today,
Most welcome.
and for making it wide open for all the members of All India Ophthalmological Society. An excellent demonstration of cases, and everything was so nice, so live, so real, and all the small things, also small tips and tricks that you all told were really useful. That can happen only in a live surgery. Actually, I think that can never happen in edited videos. So it was really nice, excellent demonstration.
Once again, thanks to all of you, and especially Madam and Sir also. And thanks to the AIOS team for this wonderful opportunity. I also thank my colleagues and my staff members who have been a part of this live surgery show today. In spite of being on a Sunday, they have been here right from the morning, and I'm really grateful to AIOS once again for this opportunity. Thank you.
Thank you.
Thank you, sir.
Thank you. Thank you for a wonderful demonstration. The whole team has worked so smoothly. Everything was so smooth.
Yeah.
The surgeries were very smooth, and the way patients have been handled also, we could see that, in the other center, one after the other, the patients were shifted and were done. So everything has been spot on. So thanks a lot.
Thank you, Aditya. Thank you, Pankaj.
Yes, thank you. Thank you. Yes.
Thanks.
Bye.
Next case.
Including the J&J, team of J&J who have supported this Surginar. So thanks a lot. Dr. Seema, thank you, everyone.
Yeah, I think we need to give full marks to J&J, because they not only cataract surgeries or the refractive surgeries, which is their domain, but also the other surgeries, and that goes a long way as far as the education is concerned of all our members from the All India Ophthalmological Society. So thank you, Johnson & Johnson, for again doing this yet again for us. And I know that there is a whole line of Surginars which are lined up, and we will be taking one by one. So thank you, everybody, and thank you, the whole audience, for watching this.